Great. I can see that we have just opened today's webinar, and the very first people are starting to join and pop in. So I'd like to just welcome everybody to our monthly webinar for Ontario Health Teams. And I invite you to drop into the chat where you are from, where you are joining us from, and please let us know who you are and where you're joining us from today. And I look forward to having all of you start to pop into this conversation. Diane from North Simcoe, Sierra from North York, Toronto, and everybody's just going to start firing in now. John from Nipissing, Rain from OWFR, French River, I'm going to guess, Ottawa Rivers, Ottawa, French River. Some of the acronyms are still emerging for me. Huron, Perth, Monroe from Great River, Natalie also from Great River. Welcome. We have people joining us from the north today. Gray Bruce, Sarah, Shelley Horrocks from Ottawa, and Kelly Kay from the Provincial Geriatrics Leadership Office of Ontario. Judy, welcome from Manitoulin Island. What a lovely place to be. And Megan from Kenora. Helen from Care First. I think, Helen, we're going to see you this evening possibly as well, too, at another event. Helen Cooper from Kingston. And Surkab from the Scarborough, Ontario Health Team. Had a little communication as we invited you, the director of that Ontario Health Team now. I really appreciate everybody continuing to join from corner to corner to corner of this province. It really is lovely to have everybody joining us to talk about one of my all-time favorite topics ever, evaluation. So thank you. As people join and invite each other or acknowledge each other, I would like to acknowledge the land on which I am hosting today's event. It is the land on which the University of Toronto operates. And for thousands of years, it's been traditional land of the Huron-Wendat, Seneca, Mississaugas of the Credit. It's Treaty 13 territory. Today, the meeting place is still home to many Indigenous people from across Turtle Island. And we're grateful, and I am grateful to have the opportunity to work from here. And I'm always reminded of the land, and particularly as we try and regenerate some natural elements to our city, to also think about reconciliation and reinvigorating and coming back to the origins of relationship with the people that were here before us. I would like to invite everybody to answer our first poll. It's a very common one for those who have been with us before. And if we can pop up the poll that have you joined us for a webinar previously? Yes, you have, or no, this is your first event. And I know that we had upwards of about 200 people who had clicked in for today. So we'll be interested to see how many people who are the returning people. And maybe some of you were at the first evaluation webinar we had in December 2019, and the first one on logic models, which I'll bring up the screenshot in a little bit, which we actually held in February 2020. So almost 5 years ago. Great. If we could, we can probably share this out now. I think most people are, and this is, just amazing. We have actually encountered thousands of people so far across the many webinars. And today we have a third of the people who are joining us today are here for the very first time. So welcome. You're in for a treat. And it's better late than never to have joined us on our journey here. Today we have an all-star topic with an all-star lineup, supporting evaluation in learning health systems, what OHTs need to know. And most of today's talk is actually going to be from the people who are really leading this work and supporting this work across a couple of really excellent OHTs and also across the network in the north. I'm super privileged that we have Dr. Catherine Donnelly with us today. Catherine is the Director of the Health Services and Policy Research and the associate professor in the School of Rehab Therapy at Queen's University. Her PhD is in a program evaluation, and she's chair of the Frontenac Lennox and Addington OHT Evaluation Committee. Her research interests are primary care and aging, and I just ran into Catherine the other day at the North American Conference on Primary Care that was in Quebec City last week. Dr. Reham Abdelhalim, very well known to me. She was my PhD student a number of years ago, and she first joined the Burlington OHT as an embedded OHT postdoctoral impact fellow in 2021 amongst that first cohort of impact fellows. So Reham is, I think, an amazing symbol of what that program and what those kinds of programs can do to support strengthening the system. And Reham has led the co-design of new strategies, policies, and services and care delivery models in the Burlington OHT. But most importantly, building that culture that embraces evaluation as a key component of implementing complex health strategies, interventions. Reham is currently the manager, population health evaluation with Burlington OHT. And finally, we have Dr. Brianne Wood, who is an associate scientist in social accountability and learning health systems with Thunder Bay Regional and NOSM University. Currently, Brianne is the Northern Ontario Rapid Improvement Supports and Exchange, or RISE, lead for the Northern Ontario health teams, as well as the research director of the Northern NOSM Primary Healthcare Practice-Based Research and Learning Network. So something we're starting to intertwine our work and our activities with as well. Her research include evaluating impacts of learning health systems, contextualized AI for communities and health systems, and health equity measurements in northern, rural, and isolated regions. So super opportunity here from all three of these people who are doing amazing work supporting embedded evaluation in the system and building capacity. And a real pleasure. Today, we're still talking about this learning health system action framework. We've been on this journey for a little while now. We actually started back in May with Rob Reed, Maureen Smith, and John Lavis outlining this whole framework for us and its origins. And we've been going through this inner circle. We've actually already done a series of webinars on the right side, which are the quintuple aim, many focused on equity. And now we're looking at these gears, the things that are driving change. We've been around through the original analytics and population data insights, through evidence synthesis, co-design with caregivers, providers, and patients, implementation, and now finally to this evaluation, feedback, and adaptation, the final gear. And in this gear, we're thinking about how do we use multiple evaluation methods to measure how well these multi-component, Reham talked about delivering complex interventions. Anything we're doing in the OHT space is a complex intervention. Working on a population and under what conditions the interventions are going to be successful. We'll talk about a little bit of that. We need to be very cognizant of context. When we talked about implementation and co-design, we talked a lot about thinking about context. And as you're looking to implement models that are evidence-based, what was the context of the original evidence and what's the context for your OHT? What kinds of evaluation logic models should be used? How do you design them? Are change processes being cemented? Are they being locked in? And what kind of reach do we see across equity deserving groups? These are all important evaluation questions to be thinking about in this stage. People involved in evaluation are going to come from quality improvement teams, performance management, business intelligence and decision supports, clinical informatics, as well as evaluation specifically expertise. And on the next slide, I just want to ask one more poll here to find out amongst the people who are joining us here. And I know there's quite a few who have some activity in this space, but let's get a knowledge of how much experience you've had with evaluation overall. Get a little bit of a sense of the strength and expertise. And I'm sure there are, and I've seen some of the people who have signed in, that I know we have people who could be teaching us some things, and we're always here to learn. So really look forward to your engaging in the chat. We'll have some opportunities for you to talk about what you've been doing, as well as ask questions of our kind of lead panelists today. And I see that we have most of the people have now chimed in, so perhaps we could share this with everybody. You never really know what these are going to come out with, but it turns out about 20%, about 1 in 5 have much experience with evaluation. About a third have good knowledge, and then nearly half have only had some exposure to evaluation. So I think it'll be really a great opportunity for us here to be learning about what OHTs themselves have already been doing in terms of supporting evaluation. And you can see some of the practices that you can be following. That's great. Okay, I just want to talk for a moment in about 5 minutes about what the practice of evaluation looks like from our perspective here at HSBN. We are the central evaluators for the Ontario Health Team, so this is kind of our wheelhouse. This is the gear we work in most commonly. So I'm just going to talk about 3 quick little things. And I say follow along with HSPN, and we'll drop a little invite into join. We actually lead Kaylee McKellar. Dr. Kaylee McKellar leads a whole community of practice. That's a more informal and ongoing discussion about evaluation, and you could join those for those discussions. Quick little drop in for me on logic models, measures, and study design in about 3 or 4 minutes. I want to know for you, when I say you've got a program you're trying to implement, in fact, I've seen OHTs, they have many, many programs you're trying to implement at the same time. And what do you think about if I say to you, you should evaluate your program, or we should evaluate your program together? What does that make you think about when I say we should evaluate? What comes to your mind? Any thoughts you have? It could just be one word or a few words. I don't want a big, long explanation, but just what do you think about? What's your first response and reaction when I say you should evaluate your program? Oh, Danya, I love your exclamation mark in capitals. Yes. Value and learning, impact, availability of data. How are we possibly going to do this? Defining the program. What is it? Are we doing it? Doing it as planned? There are some excellent frameworks around understanding the implementation of programs as well as their success. I've seen accountability. Now I see Derek with transparency. I really appreciate how often I'm seeing learning. How do we do it? John wants to know why we want to evaluate it. We're going to come back to all of these. So actually, I'll ask our panelists to think about why would you be thinking about evaluating your program? What does it look like? How do we do it? So I just want to thank everybody very much for keeping those pieces. And so keep bringing that in. It helps to flavor what we're doing. So I want to, way back in February 2020, imagine OHTs were 3 months old from the first announcement that was made in November. We were talking about logic models for OHTs, early forms of evaluating these programs. We came back again in round measures in November of 2020, and this is what our invitations used to look like in those days. We have definitely evolved and emerged since then, but these are still quite valuable, and resources I'm going to highlight that we put out then, I think, are still being used. And in fact, we are still using the resources that we designed back in 2020 for some of this work now. The next slide, just what is a logic model? And this is the same as what we originally suggested. So thinking about understanding, to number the comments that are going in there, what is it the program does? That's the activities. And what are the resources that you're putting into? What are the people? What are the technologies? What are the new tools that we're putting in place? Those are the resources. And then what are we doing with them? That's the planned work, the activities. And then coming across to what are the outputs that you can count to know that you're actually doing those things and you're reaching the people? This is like the number of people that might be in your program, the number of case conferences, interprofessional team meetings, those types of things that you can count. But really, what are the outcomes? And we're working a lot with a number of the leading projects right now in one aspect of the OHT evaluation, where we're trying to understand and delve into what are the common outcomes that we can think about across these different programs. And then finally, the impact is more of a multi-year, longer-term impact that can be on the health system for better organization. It can be on people's health outcomes and goals, but a longer-term impact of the program and how things actually look differently as a result. So that's kind of understanding the program. The logic models are really about a communication tool about what it is that you're trying to do, the goal of the program out there on the impact side. And then, how would we know if we're working towards that? Are we doing the right things? And are we actually achieving some of the outcomes that we're intending to do? Out of here, once we have laid out, what it is that you're doing, and, we have a resource there at the bottom you can follow up on later, right off the OHT evaluation space, then you need to start thinking about what the measures are that you're going to do. In all of our work, we've been taking a quadruple aim, but also with equity in each quadrant to measurement. So thinking about patient experience, health outcomes, cost, and provider experience. And HSPN has been layering on lots of measurement around all of these, which is shown on this slide, thinking about what's meaningful to people, what are the indicators that we're looking at through our spider diagrams and league tables, what are the costs looking like for total costs and monitoring that, and then also understanding about provider experience and monitoring and supporting that within a number of the OHTs, and we've been doing that work at a local level. So that's the measurement side, and you can actually think about tying your measures in to your logic model when you think about each element of your logic model. What are the resources, activities, outputs? What's the measure? How are you measuring that? Where will you get the data? What's your approach to capturing it? And then how often are you going to be reporting it? Again, this is another table as you start to think around operationalizing your logic model that's available in PDF and document form on our website, that you can use this table to start to fill in that you're doing things well in terms of your evaluation. So that's what we've talked about before in supporting early days of evaluation. You'll see aspects of this in all three presentations. The last point I just want to pause on for a moment is thinking about how do we use data and how do we think about the type of evaluation and the design that we're using a little bit. And I'm just going to kind of talk about three different approaches. One is like a case study, which is just understanding what it is that you're doing and being able to describe and tell that story well, and what are the successes and challenges. And this is an approach that we use for a lot of our work. And you can be thinking about describing that from within your own programs. You may want to be actually seeing if things are changing over time. And at that point, you really need to have this kind of before and after, measuring twice and seeing if there's a difference and how things have changed. That could be on a qualitative, but also a quantitative approach to think about how things have changed. And very often that will be your capability of that before and after. Where external parties come in or more rigorous designs can be helpful is moving into more quasi-experimental design. And that is to say, either by adding a comparison group, which says like, what happens if we hadn't done this? Or what happens to the people who didn't receive this program, or time series models. And I just want to give you a clear example that some people here may remember on why this can actually be important to have a comparator. So if we go to the next slide, we'll see here, this was work we were doing in HealthLinks, which was a precursor to Ontario Health Teams. It was actually also designed by as a Ministry of Health initiative supported. And this was what we were seeing in HealthLinks in those people who are enrolled in HealthLinks across Ontario. So the gold line at the top are the people that were enrolled in HealthLinks programs. And this was their monthly cost. We could do this in a lot of different measures, but total system cost is the one I have here, comprehensive of all care. And then we have a comparator group that we were able to use matching with kind of a sophisticated statistical approach called propensity matching. And we looked at these, so we found two groups of people and what was happening with their costs prior to starting the intervention. And then in the usual pre and post, the next slide shows what happened to the enrollees after being enrolled in the HealthLinks program. And this is what most programs were able to show, which is that costs were going up for these people. They were becoming very difficult, very costly, and they're encountering the health system a lot. And then we gave them HealthLinks and costs came down. And that is a very good success story for the people that were enrolled in the program. But the second line here now is seeing what happened to the people not enrolled in HealthLinks. And it turns out that they also had a reduction in their costs after that period of escalation. And in fact, that reduction was a little bit stronger than the people in HealthLinks. So comparator actually costs declined more than the enrollees. And one of the rationales of the program was to improve coordination and reduce total system cost. And by having the comparator, we were able to see that while HealthLink's clients' care was reduced, it also happened to people who were not receiving care. It's a phenomenon we call regression to the mean, but it's emphasizing the importance that you need to do pre and post, but sometimes we really also need to have comparators to understand, and that's where the more rigorous designs come in. I just wanted to drop that in. We have a community of practice where we can have more informal discussions, evaluation performance improvement for Ontario Health teams. It's people working on evaluation for performance improvement and supporting that work in OHTs, and it's a chance to share experience in a meeting format, not on a big webinar with hundreds of people. It's a smaller format, although they do get 100 registrants, I think, often. But it's smaller, it's group, it's more formative, and a whole number of range of topics that have been covered. The recent topics that have been up on the next slide are, for example, assessing learning health system capabilities. We talked about a self-assessment tool. There was an analyst cafe last month, just sharing experiences and challenges. And in December, there's going to be a focus on evaluating digital and virtual care solutions. These are held on the second Tuesday of the month, so just 2 weeks before this webinar. And here's how you sign up. And Kaylee, who leads these, is dropping the links into the chat for you around the Ontario Health Team shared space. This is on the hosted between Rise and Quorum from Ontario Health. And find the collaboratives page and look for evaluation performance improvement. It is, no joke, the hottest collaborative team out there outside of the QIPs, which are a mandated initiative. This is the hottest commodity, the most active collaborative. Welcome you all to join us on our monthly events. That's enough for me. We really want to get on to today's big best of the show, starting off with Dr. Catherine Donnelly and her work and support in the FLA OHT, and then we'll move on to Reham and Brianne. If you have, Brian, seeing you had the similar results. Well, I don't know, we learn a lot of things. I also say there's a lot that we learned, Brian, from HealthLinks, and one thing is that the collaborative tables that started to come together through HealthLinks that had not met each other, some of them were the foundations for Ontario Health teams today. And so that building on partnerships and relationships is one of the biggest accelerants we can have. So all was not lost, though, yes, we didn't hit that marker in the evaluation. So I'm happy to answer any questions or join in a chat. But what we want to do here now, I think today, is have Catherine, Reham, and Brianne talk about their experiences, and then we're going to kind of come back together and have a bit of a joint discussion about this. So feel free to drop your questions, comments in the chat. Some of them we'll answer along the way. Some of them we'll capture in that end discussion. Catherine, let me turn it over to you.
Great. Thanks so much, Walter. Yeah, I think you've laid a wonderful foundation for my talk. So I will just get you to switch to the next slide, but just wanting to highlight that I'm going to be talking about a bit of our meandering path over the last 4 years from an evaluation perspective. For those who haven't been here before, just starting out, I feel like this might assure you that there's, a path that we've all been moving along, and there's no perfect way forward, but again, collectively learning from our collective efforts. So I just want to give you a little bit of a context of where I'm coming from. I represent the Frontenac, Lennox, and Addington OHT, and so you can see the visual. Our attributed population is very close to our geographical sort of, I guess what I would say, boundary. So you can see that we have about 220,000 people in our FLA OHT, and we span both rural and urban areas, which not all OHTs do. So we have both of those lenses on our mind. We have a slightly older population. We have also a population that's fairly homogeneous from an ethnicity perspective. Approximately 95% of our people have English as their first language. We do have a higher proportion of French speakers at about 3% as well. Our focus in our region is very much from a primary care lens. Our flow-through agency is actually a community health center, so it keeps us very grounded from a primary care lens, and really that is our main focus in our OHT. And you can see we've got people around the out as core to our OHT. Next slide, please. I'll just go through quickly, and I just want to highlight our mission, and this is like central to our focus from an evaluation perspective. Our objective is to have everyone in our region have a health home. And so again, thinking about that health home and primary care, and many people have heard, I'm sure Dr. Jane Philpott speaking now of her focus on a neighborhood sort of focus model, and that's very much informed our work and in turn our evaluation in our region. Next slide, please. And I wanted to highlight this because this is our organizational structure. And I just want to say from the very, very beginning of our OHT, when we started to come together to write our application, evaluation was at the front and center of all of the discussions. So not only did we have to actually submit what our outcomes and indicators were going to be, but again, we were thoughtful from the start of how we can actually shape our work from keeping that evaluative lens to inform us as we went along. So you can see one of the core support structures is our evaluation group, which is on our transitional leadership collaborative as well. And you can see that all feeds into our primary working groups, which I'll speak to in a moment. Next slide, please. So I'm going to share over the next about 10 minutes, which is going to be a rapid fire about what we've been doing, and just a little bit of a reflection on the last years, some of our key initiatives of focus, but really highlighting the evolution of our thinking. And Walter's sort of alluded to this evolution of even HSPN's work and support over the years. So our very first focus, we came together around our application and we identified our priority populations and indicators. Next slide. And so our initial priority populations were 4 groups of people: people who are aging, people eligible for palliative care services, people living with mental health, and hospitalization. So again, we picked our priority populations. Next slide, please. Well, I think there might have been another one. Was there? No, maybe not. We picked our priority populations and really from there started to work with our communities to build what the actual interventions or programs are going to look like. So I wanted to put this as sort of our first building block. So we came together around these 4 populations, and then we had to develop frameworks around how we're going to create our interventions and programs. So again, very forward thinking in my mind from an evaluation perspective. Each one of these working groups had a community member co-lead, a primary care physician co-lead, and an evaluation representative from our evaluation working group. So we wanted to make sure we had the voices of all 3, remembering that primary care was sort of our prime focus. So over that course of the year, we co-designed what that programs were going to look like for each of these populations. And as part of that co-design process, and again, thinking about a logic model is really your program theory about describing what that looks like. So each of the evaluation representatives in the priority populations were tasked with helping to develop a logic model for each of the groups to help describe and also start to layer on what our outputs were, what our outcomes were, and linking those with both the CQIP indicators, but our TPA indicators that we were responsible for reporting back to. And I'm just going to get you to share the next slide. And I am not going into this in any gory detail at all, but just to share with you that each of the working groups, again, really worked with each of the groups to help start to describe what we were doing for each of those programs. And so the logic model was extraordinarily helpful for helping us to systematically document what we were wanting to do and the influence and the impact that we were wanting. And you can see, I'm not going to go in detail, we made sure we had TPA and CQIP indicators, and you can see we used the quadruple aim as our guiding focus. Next slide. In that very first year, so what we did was we rolled each of these, I'm not going into this in detail, we rolled each of our logic models for each of the 4 working groups into one visual for our OHT in terms of thinking about roll up of our outcomes. Next slide. We also realized in that first year, so much of it was around co-design and describing the programs that we were starting to come together around, that we realized there wasn't any data per se in that first year. It was much about laying the foundation. So what we did from an evaluation perspective, we met with each of the groups and we actually held some focus groups to describe what the activities were and what were the success stories. So they weren't necessarily I met from data this outcome, but again, much more of a qualitative approach in terms of what did they think they met, what were the sticky points, and what work do they want to get to. And so this very much allowed the groups to feel like they were moving forward without feeling like there was something that they were missing in terms of implementation. So again, those very early days from an evaluation perspective. Next slide, please. So that brought us, so again, thinking about our priority populations, thinking about how we used evaluation to describe what we're doing, and also describing those stories of early success. And then we looked around the table, our evaluation group, which was a representation and still is of faculty members from Queen's who do evaluation work, as well as community members. And we realized what we needed in year 2 and onward is really the data that can start to help inform those programs to start to make changes and tweaks. Next slide, please. And we realized, even though we keep talking that we're a learning system, and that should be we collected our own. And I saw in the chat that people talk about like this idea of missing data. And so we realized, and I've got this slide, this scale here, because what I wanted to share with you is our big struggle. Our evaluation group is largely volunteers. I merely volunteer as the chair of the evaluation group. So I didn't at the time have vast resources that we could do a lot of primary data collection. I put the black box there because while there is access to large data, which can be helpful to sort of have a North Star look of where your OHT was, it wasn't the granular data that we needed to actually start to evaluate those test of change programs in those priority populations. And so we really struggled going into year 2 to try to get local data that we could action. And you're going to hear from Reham shortly about a great example of how they narrowed in on one target population and were able to get data. I will say that we struggled immensely. So we came together as an evaluation group and thought to ourselves, what we really want when we think about the quadruple aim is we want to hear from the people in our OHT, and we want to hear about their health and well-being. So that started us on a focus in year 2 and 3 to actually reach out and see what it would be like if we created a patient outcome and experience measure, and we leaned heavily actually on HSPNs. We worked with 4 primary care organizations and public health and actually deployed what we're calling as our FLA OHT patient wellness and experience measure. And we're using part of the HSPN, thinking the EQ5D, as well as the Community Health Center socio-demographic questionnaire, so we can bring an equity lens. So we deployed it and tried it. And so we were able to get 1,200 experience surveys completed. And you can see we tried it in many different ways to see how best could we collect that data to inform our OHT. I won't go into detail here. Next slide. Not only did we collect the data from a learning health systems perspective, in that pilot stage, we actually gave each of the participating clinics back weekly and monthly data sheets to explain, what their patients were looking like. And so from that project, next slide, please, we really learned about, as an OHT, if we are going to collect our own data, our own prem and proms, what do we have to do to support our primary care network and our organizations? And what we learned really, this notion is that if we're going to actually collect data, one size does not fit all. And each of our partners is going to need significant supports to not only implement the data collection, utilize the data, and again, think about some changes that they can use from a QI perspective. So again, thinking about also shifting this lens in our OHT to think about, how can we make sure that we're collecting data to inform from a learning health system perspective as well. So again, just walking us through the first years, picking our priority populations, co-designing the intervention, describing it with a logic model, and trying to figure out how we can start to collect data to feed back into primary care, knowing that data is such a struggle. And next slide, please. And so that brings us to where we are now. And so Thank you. In year 3 and 4, and just which is where we're at, it's been largely a time to regroup, because many of you on the call here are probably trying to figure out where you focus your efforts. There's just so many moving parts in the OHT, so much going on. How, from an evaluation lens, can we have the most impact and inform the most different places in our system? And so those initial 4 groups have changed over time, partly from the information that we learned as we were developing the programs through the logic models, partly because new funding sources and opportunities have come in. And so in years 3 and 4, we were left with a whole different landscape and trying to figure out our small evaluation group, how we could most be impactful and how we can most be focused. Next slide. So what we decided to do, and I don't know if people feel like this as well, again, most of us are volunteers trying to leverage the good work of our partners and the data that exists, but it's sometimes difficult to rein in and have a concerted, focused effort in terms of evaluation. Next slide. And I'm just going to end here. So in years 3 and years 4, we've decided to tighten our evaluation group. We had a large evaluation group that we were meeting with regularly, and it was very hard to remain focused in terms of what our evaluation questions and goals are. We've become one of the 12 leading OHTs, and we've been able to hire Connor Kemp, who's fabulous, who's our performance and evaluation lead, who has a full-time role helping and support the work of Quest. And these are some of our other key colleagues on the Quest team. Next and almost final slides here. So we have decided to focus exclusively from a Quest group on looking at how we can evaluate the concept of health homes and this idea of having care closer to home through a neighborhood-focused approach. So we've honed down our logic model to think exclusively on the processes and the characteristics of primary care and the health outcomes associated with a health home model. Next slide. So we've decided now to, again, frame everything around the health home in the last 4 years. And we're looking at 3 targeted activities for this year. One, we're focusing on getting the patient experience and wellness out to our primary care network. And we actually have a data support person that's going to be focused specifically on this role. We're looking at working to map our neighborhoods. And so we're working with the Community Health Profiles Partnership to actually break down our region into neighborhoods so we can start to align primary care with our neighborhoods in line with the focus of health homes. And we're in the midst of meeting with each of our primary care teams to look at the current state of where they're at in moving towards what we see as our health home model. Last slide here, I think. So again, it's been a meandering path, starting from when we first got together to build our priority groups. And what we've really learned along the way is the crucial need to align outcomes and indicators across the many projects that will be happening in your OHT. Working closely, and again, Walter alluded to this, like with partners as much as you can to coordinate the data that's coming in. We have several large evaluations that are being conducted in various projects in our OHT, and working with those larger evaluation projects to make sure what the data they're collecting, how it aligns with our focus on moving to a health home. And again, thinking about really focused on that routine deployment of our patient wellness experience survey. We've heard from our council that what they really want to know is about the wellness and the health of the people in our networks, and really focused on getting that wellness data. So I guess I would say to everyone on the call, stay focused and have a plan, sorry, just 2 last things there. I just had to remind myself what they were. Do you mind just going back to that slide? Bite-sized projects, again, we started very large and we worked our way down to much more focused, and build on your work slowly over time, each of your learnings, and we'll get you there. I'll just end on that last slide. Thank you.
Wow. Thank you so much, Catherine. You distilled a lot of information in a very brief period of time. I think
Sorry about that.
No, that's great. That's absolutely amazing, because I think it's really a leading light, and we've kind of been seeing how you've actually just gone out and done things. right? You haven't waited for other people to come along and help. Now, there are some other people I think might need some more help and support. Some of the participants today going, oh, well, I wish I had that kind of a resource in a Queen's University and a Catherine Donnelly nearby. But I think it does lead the way of just trying things and not waiting for other people to solve your problems, but coming in, trying to say, what data do we really need? How do we collect that and operationalizing? And I think hats off to your group for really kind of showing this now across a number of pieces. And I love seeing logic models, and I can see implementation science, some of the things we talked about in implementation. I'm sure I saw a consolidated framework for implementation research framework in there. But just starting in to think about actually activating lots of what we call the gears in the Learning Health System Action Framework. So thinking about the populations, thinking about the evidence-informed approaches, and then thinking about the implementation and evaluation of these models. So thanks so much. We're going to learn now, and I'm sure that, and yeah, some people are definitely finding it inspiring. So other questions I'm sure will come on board, and we'll stay alert to those. But Reham, as I'd said, was one of the first Impact Fellows, which was intended to build capacity, particularly around evaluation in the health system and in Ontario health teams. And so now, Reham, you can talk about the work that you've done over the last number of years in lifting up this aspect within Burlington. Welcome.
Thank you so much, Walter. It's a pleasure to be here. Maybe you can move next, please. So I wanted to start with a little bit about the Burlington OHT. So we have an attributed population that's just under 250,000. We're mostly urban, suburban. In terms of geography, 25% of our attributed population are actually 65 plus. So it makes sense to have vulnerable seniors as a priority population since the inception. In terms of our internal capacity for evaluation, we are a very small but mighty team of 2, including myself and a part-time data analyst. However, we are supported by a huge culture of understanding, commitment to evidence-based decision-making, measurement, and continuous improvement. The approach that we're taking since even before I joined the team is that we use a learning health system approach to planning our services, monitoring and evaluation, learning, and then assessing the impact and whether we scale or redesign any intervention that we have been implementing. Next, please. Today, I'm going to be walking you through one example, so one program from start to end in terms of evaluation journey, just to be a little bit giving an example based on all the amazing things that we've heard from Catherine now, how to put this into action, kind of. So that is called the Community Wellness Hub. However, everything that I'm going to be sharing today has been replicated to all our other programs. So the Community Wellness Hub is an alliance of health, housing, and social service providers that coordinate and deliver services to seniors at the place of their residence. So think about a North building, so a naturally occurring retirement community. Most of the individuals living there are living with lower than optimal social terms of health. Of course, they're high users of the healthcare system. So how can we create a team out of all the providers that are already visiting this building to create an integrated care system within this building? For that, the main values of the program would be proactive, holistic, and integrated care, of course, interdisciplinary teams who are working as one team, serving equity-deserving populations, which are seniors living with lower than optimal social terms of health, and of course, being cost-effective and being able to scale it. All sounds nice, right? Okay, we'll keep going. Next, please. In order to achieve this vision, the main components of this program is an on-site community connector. So you can think about this person as the glue that puts everything together. We have the interdisciplinary service providers who act as a team currently. Most of the time, it's anywhere between 10 and 20 providers within any of the buildings. And we are trying to kind of enforce this vision of it's a team. And I'm going to revisit this while I'm talking in a couple minutes. We started with one hub in one building. This was in 2020. Now we are having 8 buildings that are covered. 4 in Burlington, 2 in Oakville, and 2 in Greater Hamilton Health Network, supported by the Greater Hamilton Health Network, OHT. And we are expanding to 2 more in 2025. Next, please. Exciting, maybe promising, but was the beginning like that? No, it wasn't. So I'm going to share with you now what's happening. As I described the hub, and as Walter said earlier, that any intervention within an integrated care network can be viewed as a complex intervention. The only problem is that once you start thinking about the evaluation, the big question that always pops up, did it work? However, most of the complex interventions, you can't answer this question that easily, and it can be the first question, the first evaluation question that you're asking. Next, please. Why? Because if you're asking, does it work or did it work, you're just completely ignoring everything that happened in between, from planning and design, implementation, and then expected outcomes. There's lots of layers of complexity that you need to pay attention to. Next, please. In order to kind of unpack the complexity, the easiest and the most convenient method to use is actually, I know that you've heard this a lot. I know that some people find it a little bit hard to use a logic model, but let's think about it from a questions perspective, like evaluation questions perspective. So any logic model starts with inputs, something that you use to build your own model. And then this would be transferred into activities, so intervention components. And then when implemented well, these will lead to outputs. And then over time, this will lead to outcomes. And then like maybe 5 to 10 years from implementation, you want to see a system level impact. In order to test if you have done your inputs and activities right, you are looking at one type of evaluation called implementation evaluation. The type of questions that you're asking in this type of evaluation has to do with, do we have what we need to implement and achieve our vision? And then, did we implement the vision as planned? What do we need to revisit, if any? In terms of the outputs, it's all about how are we doing on a day-to-day basis. And for that, you are looking at continuous performance monitoring. And in order to tackle the outcomes and impact, you're using one type of evaluation called impact evaluation. And for that, you're asking, are we making a difference? But more importantly, why and how? Because if you don't know why and how can you revisit or scale up? That's a big question. Next, please. Back to the Community Wellness Hub. In order to tackle the continuous performance monitoring, we created this dashboard. This dashboard helps us answer these questions. How are we doing on a daily basis? Are we meeting our targets? Are there any trends, whether they're positive or negative? Why is there a trend? And if there is a trend, what next? In order to answer these questions, this dashboard data is collected primarily by our providers within the hub and managed by the community connector who's overseeing the hub operations, and then shared with the data analyst who would run the analysis, put it in this beautiful dashboard, and then bring it back to the operations table where they look at every single number and answer these questions. And if they are able to revisit any of their operations in order to refine a little bit to tackle any trend, whether it's a positive or negative, they would. If any changes that are big enough that require maybe new funding or maybe a new governance structure, then this will move one step forward to the leadership committee where they can make decisions like big decisions like funding, for example. Next, please. Okay. I'll go like few steps back to the implementation evaluation. Do we have what we need? When I joined the team, this program has been implemented for about a year and a half, and it was over COVID. And the big question was, why are the outcomes that was stated in the original logic model are not happening? Then I was like, maybe because we need to see if the vision that was created on this logic model was actually implemented or no. And for that, I proposed this implementation evaluation to answer these questions. Do we have what we need to implement and achieve our vision? Did we implement the vision as planned? Does everyone in the team understand and operationalizing the vision as it was stated? And the main topics of the evaluation looked at the definition, the vision, the operations, and the impact. And I used a case study approach, as Walter explained earlier. And this case study methods included document analyses, observations of all the interactions that are happening, as well as focus groups with leaders, providers, and users of the hub. Next, please. Sorry, yes, keep clicking. Sorry about that. I forgot to remove the animation. Next, please. One more. Thank you. When I proposed this idea of let's evaluate the implementation, this was a little bit of a new concept at that time for the team. And the main challenges were, our program is too complex. Why do we need to do more? And I was like, it takes time to create a logic model, but it's important, so let's do it. We already know what are the problems. Let's just spend this time to solve it. And I was like, okay, that's perfect, but have you heard from all stakeholders? Maybe you're just missing some pieces. We're so focused on running the program right now. We're just out of COVID and we need to focus. We don't have time to evaluate. And my answer was, evaluation is not just a thought exercise. The outputs should be applied to improve the program. And I have to acknowledge that the leadership commitment to evaluation, understanding if the program is working and why or why not, was a huge support that I had from the beginning. Next, please. Okay, what did I find? In terms of the definition, there wasn't this consistent definition of the program. Every single layer of the organization would see the program from their own perspective. There wasn't this like one definition of what a hub is or should be. In terms of the vision, yes, there was a vision written on paper, but was it instilled in the minds and the workflows of every single person? No, it wasn't. And in terms of the operations, the team didn't operate as one team. Yes, they're using a care plan, but everyone's still using their own consent form. Yes, they all work on the same place and they have weekly rounds, but every one of them is still using their intake assessment form individually. So while they know that there should be a team, they communicate together well, but still the workflows are not streamlined. And the biggest piece is that they didn't have a shared record that all of them can use at the same time. And in terms of measuring the there wasn't this like one big impact assessment that was enough to reflect the outcomes and the impact of such a complex intervention. Next, please. So these were kind of the findings, and in order to some buy-in from everyone, because sometimes when you're sharing some negative results, that's like a big problem. How can we share that? What we did is that we had a very big gathering of every single provider, all the residents in building number 1, and also policy makers and some local politicians who can support funding in case we need some funding. And we shared the evaluation results not as a negative story, but actually a positive story where that's what we're able to do to date. These are the gaps as identified by you as part of the evaluation. And then how can we enact these results to make sure that we have an action plan to make our hub better? It was a collective responsibility, and the action plan was on all of us to implement. Next, please. After that, we took lots of maybe 6 months to a year just to revisit everything that we're doing. And after that, we started measuring the impact of the hub as a stable, complex intervention. And what we're able to do is that we're able to prove that there is an improved self-perceived wellness in a tool that we created, because one of the things that we heard from the providers is that using the RAI tool was a little bit hard, and it wasn't like patient-centered or provider-centered. So we created our own tool that is easy to be used, and also it's easy to be repeated. We also were able to track that 14%, that there was a 14% reduction in non-urgent ED visits for the hub members as compared to comparable population in Ontario. And also there was a 31% lower rate of hospitalizations as related to ambulatory care sensitive conditions. And you can think about these conditions as these type of hospitalizations as related to conditions that are better managed in the community, such as diabetes, hypertension, these kind of chronic conditions that you can support outside. Also, the length of stay for the community wellness hub members was lower than the average. And when you combine these numbers together, and if you're thinking that if we were to implement the Community Wellness Hub to serve 100K of seniors living in Ontario, a yearly cost saving for the system would be almost 90 million per year, just based on this one metric. Next, please. In order to cover the other components of the quadruple aim framework, we also use a member experience survey. And we augment this with some qualitative questions or focus groups with our members. I won't read all the codes, but it's the whole idea here is that these measures are very important. They are yearly, so we survey our members yearly. Next, please. Also, upon the expansion of the hub to other buildings, we recognize that there are some of the residents who are not able to communicate or answer surveys or receive surveys in English. So we try to work with some interpretations within the community to support the service provision, but also we translated all our evaluation tools that are patient-facing into 5 languages, which are the 5 languages other than English spoken across our hubs. Next, please. We also have a provider experience survey. Next, please. Next, please. Yes, thank you. So that's a dashboard explaining the survey results. You can look at it later. I won't waste your time now about that. Next, please. I think this is, for me, is the most important slide on this deck. What does it take to implement evaluation findings within an integrated system or within a system of providers that are not working together, like in one organization, for example, like when we don't have a mandate for evaluation? These are what I've learned while working within the BOHT. First of all, engagement from start to finish, especially leadership engagement, was key to the success, if there was any success in the evaluation process. Also, be open to innovation. Be open to say, like, let's try something new. The whole idea of this one care record, a digital record that all the providers who belong to so many organizations can access and use, was an innovation. But we're able to prove that it's working, and we're able to find some funding for it. Also, seek funding opportunities whenever they are. Be open to fail, but fail forward. Create sense of urgency while you are planning for the evaluation, implementing the evaluation, or sharing the results and enacting the results of the evaluation. Sense of urgency is always important. Also, sense of ownership is important. Change management all through. And it's always a collaborative approach. Next, please. The hub is pretty popular. Over the last 3 years, we presented 50 times about the hub, internationally and nationally and locally. We've also have been featured in the Toronto Star in summer, and also the Ontario Hospital Association wrote an article about the hub and its impact. Next, please. Thank you.
Wow, that's a great opportunity to dive in and understand how you're just building capacity and focused and doing, I think, that focused work, really, that Catherine had referred to kind of towards the end, is like, staying on point, having focused, having a plan, taking bite-sized projects, and then building it over time. So I think actually that's couldn't have asked for a better way to exemplify that advice. And I really, building the capacity beyond yourself too. Our questions about resources, we might come down to the end, back around some of those general questions to all the panelists, and we'll have a discussion around here. For now, I'd really like to learn a little bit about what Dr. Wood's been doing in the north, where it is, I wouldn't say resource poor, it's almost like one level down from resource poor or low resource evaluation. Sometimes we talk about low resource evaluation. In the north, it is almost no resource evaluation. So how do we do this, and how do we share? Because sometimes some of the issues are the same, even if the priorities are different.
Thanks for naming it like that, Walter. Yeah, we're unique, We're unique, and thrilled to see some of my Northern colleagues in the participant list. So hi everybody, I'm Brianne. And I'm really passionate about learning health systems, so I was so privileged to be able to present today. Next slide, please. So I do want to acknowledge I am calling in today from Thunder Bay, the traditional unceded territory of the Robinson Superior Treaty, signatory 1850. I work with Northern Ontario health teams, and I'll dig into what does that even mean, that there are many. But I think that this is really important for reasons that Walter acknowledged at the beginning of the presentation, but place is so important to our context and to what populations and communities need, and particularly acknowledging and also working towards self-determination of First Nations communities in the region. So 6 treaty areas across 90% of Ontario's landmass. Certainly reconciliation is a practice, it is dynamic, and where it's really relevant for learning health systems is acknowledging, recognizing, and working together when knowledge systems work and look differently. And that's really important from an evaluation perspective too. And I am by no means an expert in it. And I can point you in amazing leaders in this area if you would like to learn more about Indigenous evaluation as well. Next slide, please. So in the next 10 to 15, I'm hoping to give you a little bit of background why learning health systems evaluation looks differently, feels different in northern, rural, and isolated settings. As noted, we are unique. I'll give you 2, I'm not going to use the phrase case studies because I guess it is case studies, but 2 examples of basically ongoing challenges and potential solutions that we've had to some of those challenges, specifically related to evaluation. And then I'll wrap up with what have been my learnings, and maybe some of the other teams can reflect on, whether these relate to your experiences too. Next slide, please. So again, some of you may have seen me present before. I really come back to this slide, but it's really great because someone asked very early on why evaluation, and both Catherine and Reham actually addressed it specifically in their presentations. But the Northern Health Equity Strategy, published in 2017, along with the report by Health Quality Ontario, showed that there are pretty substantial differences in our traditional population health outcome indicators. So our life expectancy is lower, variable west to east. We have higher rates of hospitalizations for most conditions, emerge visits for most conditions, person years life loss. So, for the epidemiologist and evaluation people, our pop health indicators do look worse among commonly measured outcome indicators. And so this health equity strategy was great because it came out with specific recommendations about how we can begin to address this with a collective and Northern specific approach. And I'm here to tell you, 7 years later after publication, all of those recommendations are still true today. And again, specific to evaluation. Now, this was more pointed towards some of the hospitals, but hospitals play a huge role in our Ontario health teams in Northern Ontario, that there is no dedicated healthcare strategy. So flagging, we need to consider the Northern context as a reason to specifically plan, implement, and evaluate programs for Northern populations, communities, and health systems. And in particular, big underscored, emphasized statement, programs for patients and healthcare staff in Northern Ontario are not regularly evaluated. Okay. So there's rationale for my work and for a lot of the work that people on the OHTs are doing right now. Next slide, please. So a little bit about what the Northern Ontario context is, and again, a lot of uniquenesses, and I think many of you will find some commonalities with your own experiences and contexts. So we have 11 Ontario health teams. I screenshotted Inspire's website to give you a little bit of a sense of where they are where the service providers are, although that we have some challenges with as well. We do have 3 in the initial 12. Primary care is often the only care. And I actually, again, screenshotted this picture from a 2011 ICES report. And so those little red dots that you see, people living in those communities have to travel over 60 minutes to see a primary care provider. So it's a little bit more challenging even for hospitals and emerge departments. So just so you know that travel and I think, no, you can't really see the road system, but some of those people also have to fly to primary care providers. So sometimes it's the only care, and it might be delivered in unexpected places. So we collaborate. So this isn't all about all the gaps and disparities and inequities we face. You know, there are a lot of strengths that Northern populations, communities, health leaders demonstrate, and collaboration and connection to our communities is one of those strengths. And also, you know, I keep talking about Northern Ontario as though it's a singular entity, and really it's not. We are incredibly diverse. There are over 100 independent First Nations communities in Northern Ontario. There are heavily Francophone areas. We do have some more in our urban centers. There are higher immigrant populations, but just by the reality of being in the north, we are often thought of as a singular entity and other to perhaps the more mainstream Ontario population. Next slide, please. And so what is unique about this context? Why is it important? And so I've included the Learning Health System Action Framework here too. And so we do have a smaller workforce. I think I noted a couple comments in the chat, and that leads to generalists. We have a lot of generalists. We hear that in clinicians a lot. We hear rural generalists because primary care providers often have to wear the hat of specialist. And so in the evaluation context, that means that our evaluation experts are also going to be, you know, doing the QI, doing the reporting, being project managers. Perhaps they're clinicians, you know, wearing so many different hats, and that has implications on the kind of work that we do and how we work together. And again, we collaborate because we need to, and we're good at it. So a lot of what I'm talking about is actually working between and across Ontario health teams. And our pop health profiles, our priorities, our needs are often different from, say, the provincial average or the provincially stated priorities. And so that's something that we have to balance. How do we move these provincial directions forward, or even regional priorities forward, when we have to also focus on what is most important to the populations who we serve? And I'm coming from Nausim University, but I work with some of the other academic institutions up here, other universities and colleges, and they explicitly identify that they want to be socially accountable. And so being accountable to Northern Ontario means providing value and the communities finding value in what they produce. And so there's the embedded, the value of an embedded evaluator or researcher. Next slide, please. So how does our health system context influence evaluation? Next slide, please. So I'm hearing this from perhaps non-Northern OHTs. Some OHTs might not have evaluation capacity on their team, or data or measurement, you know, and so not only are there accountability implications there, just being able to do the reporting that needs to get done, but, you know, to be able to do the really cool logic models like that we've seen in the previous two, we need to have the dedicated evaluation expertise at the table, which we've heard. You know, this has to come from leadership, that this is important. And luckily, all of the OHTs realize this and are trying to strategically develop ways to build capacity and also provide capacity where it currently sits. And so, the example that I'm giving here is in the Northwest, although the Northeast is also working similarly, and they work across OHTs as well. In the Northwest, they're creating a structure to facilitate evaluation support and guidance for data-related efforts. And so this is, I'm pulling from Catherine's presentation where it's aligning some of the need to do's like CQIPs, different reporting to funders, as well as the actual things that matter, the evaluation pieces. And Reham made a good point about those. And so we have this regional working group for data measurement and evaluation, where there's a standing committee that brings together these different pieces of expertise, and it brings in some of the local people doing some of the work, or wearing one of the data measurement evaluation hats among their entire workload. And so we've got a big scope of work. So bringing together people, yes, we want to do evaluation for things like integrated clinical pathways, for things like, primary care networks, for example. I'm pulling from some of the accountability pieces. And that means determining metrics, producing logic models, coordinating data collection, et cetera, filling out those matrices that Walter showed in the beginning. Next slide, please. And so we're pretty early. I'll tell you that we're pretty early right now, but we have noticed a few things. So this is really cool because we do have 2 I-12s in the Northwest and 2 non-I-12s. And so this alignment is allowing the 2 non to sort of stay in the loop and know what's going on and have that additional evaluation and data capacity. We are now able to do some data and evaluation things and plan them strategically in ways that didn't exist before. And also we're trying to build capacity so that it's not just staying within this group, but we can invite others, and we can make evaluation sexy to other members of the OHT, to their staff. And how do we build that capacity? And this is really helpful to align with what's going on with the digital transformation. And so that's really big from a data collection perspective. How do we align with some of the new data structures and infrastructure that's going in? From the hotspots or perhaps challenges, yeah, so there's a lot that this group is being asked to do, and it's really hard because, coming back to that other slide, we're wearing a lot of hats already. So how do we manage all of the evaluation asks, with a small group and attending different meetings, that sort of thing? So, which is my second point, all of the meetings, lots of meetings to go to. Because it's important to do things collectively. And also, how do we respect local priorities and wanting to do things a certain way and what's meaningful there with sort of the regional consensus? Those are things we're working through. Next slide, please. So the other piece is, so our health system looks different, but so do the populations, as I alluded to. Next slide. And so as a result, we have to think about data differently. And again, both Catherine and Reham spoke to this as well, but I'm thinking of Catherine's slide with the black box. So what we're getting from the central resources, who are amazing, by the way, but I'm thinking of Inspire PHC, some of the reports, we often have the asterisks. Oh, don't, don't make too much of this. It's an incredibly volatile indicator. We have small sample sizes. So 90% of the landmass, 6% of the population of Ontario, and then across 11 OHTs, like pretty small. The way that people access healthcare looks different. So we don't trust OHIP billing that much. Emerge visits, actually, they're probably more common because that's where primary care providers, i.e., the providers in the community, are choosing to see patients because they need to keep the ER open. How do we deal with this? Perhaps elephant in the room, not elephant in the room, Indigenous data and knowledge sovereignty. How do we honor this? Recognize First Nations, Inuit, Métis people's right to own, control, access, possess their data. But then how do we also do this in a way that we can do evaluation work in a way that acknowledges that our health systems are working with Indigenous populations too. And so I've done a shout out to Memo Ayamoin, which is a collaboration that works with ICES and Dr. Jen Walker to do some really amazing work there. And so what we're hoping to do, actually, that regional collaboration, as well as some of the teams in the Northeast who are great and enthusiastic too, is Northern Health Equity Strategy 2.0. So we're going to develop an equity-centered data strategy that allows the communities to own the data. And I'm using communities in a very sort of vague sense, and that's because we don't have clarity on what it will look like yet. Next slide, please. And so, yes, we're hoping to move forward again, super early in this, but it's going to allow us to answer those meaningful evaluation questions. Luckily, there's a lot of interest in this. In the OHTs, in other academic partners, other health system partners, let's move it forward. As I said, it's going to allow us to see whether, whatever it is we're evaluating is actually doing things that we're intending for it to do. And Reham spoke really nicely to that. And of course, it is a collective coordinated approach to advance some of the things that we're being told to advance, as well as the things that we want to advance. And so some of the hotspots, actually it was something that I say a lot, and I'm sure others on the call do. Sometimes we just have to accept the data as it comes. It's not perfect, but it's good enough. But sometimes it isn't good enough. Sometimes it's not. And so, yeah, I've made a little comment about the law of large numbers here. And how do we resource this? How do we just keep adding more hats to the people that we have? So next slide, please. And I think this is my main wrap up. Awesome. So team-based worked best. I've heard the others speak about that as well. Capacity building is part of the strategy. So we're trying to, democratize evaluation, but how do we make sure that others are involved and engaged and maybe eventually can independently help create those logic models or data collection strategies, without necessarily the support of the, whole team. Data collection is inevitable. Again, I've heard this now from both previous presenters. Walter alluded to it too, and know the so what ahead of time. And Reham really spoke to this, and as does the learning health system action framework, is once you have the data, you have to do something with it. So what are we going to do? And I think that that's really important too. And I think that's it for me. You can go to the next slide, but it's just a thank you so much. So with that, thank you panel and presenters, and I'm looking forward to questions.
Thanks very, very much, Brianne, for joining. And very much to Catherine and Reham also for sharing your many experiences with us today. And perhaps we can take down the slide and have a little chat. I'm looking to get my camera off there, and we could just highlight the four of us and have a little bit of a discussion. I'm watching the chat for questions that we might have now. And I see there's lots of compliments coming in. So congratulations to all for your presentations. They've been very well received and inspirational, I would say, to our participants. I hope not at all intimidating, because you all do very good work. I want to come to one or two questions that kind of came up a few times in the chat. One is around resources for doing this work. And I think, Brianne, you talked about that towards quite a bit throughout, I think, resourcing and what do you do and setting priorities and acting as a team. But Reham, I think you said it's largely you and you have an analyst. How do you even manage to make sure you have an analyst? And Catherine, there are other people, and you mentioned the new, I think it was Connor, is the new person in for your team now and helpful. How do you organize and ensure you have those resources available to yourself? So I'm going to start with Reham and then Catherine.
Thank you, Walter. I think it's a game of prioritization, right? It's like you get the same amount of money for your funding each year, and then it's on leadership to try to decide, do they really need an analyst? However, some other OHTs who maybe were not able to find some funding for such roles, they were able to lean into their partners For instance, many of the OHTs who are collaborating with big hospitals who do have analysts and do have evaluation specialists, just use them. Our OHT is pretty small and we don't have this capacity, so we have to hire for them. I believe, Brian, like in the north, you need like more than that, right? Like more than one hospital, more than one team. Probably you need like collaboration across OHTs to find one person who can support. So I think it's very depending on the context, Walter. I don't know if I answered though.
Yeah. Oh, I think a little bit definitely in making a clear argument. A little bit of it comes back to the why that was asked by John very early on in this. Catherine.
Yeah, I was going to say really the same things. I think it's the value that the teams place in evaluation, and I think really identifying why, how important and meaningful that is. So we've had positions because we're an accelerated OHT, so we were able to take some of that funds that came with that and leverage it, and we have 2 positions. The other thing is we were going to, just to Reham's point as well, is create a data table. So like who sits around our region with significant data holdings and data resources. That's our next phase. And then I would also urge people to consider targeted funding projects. So that's really was how we were able to move significant activities forward. So we had money from like different pockets that we applied for, and that was able to give us people to work on those projects.
Yeah. Thanks for that. I say we do evaluation. I kind of usually think that the value of evaluation is substantially in pouring a lot of resources into things that aren't creating value. And I usually think that at least 5% of your resources should be spent on identifying whether you're actually doing what you intend to do, as a bit of a benchmark. On the this gear that we talked a lot about evaluation today. This gear, we actually talk a little bit about evaluation and feedback. And so I want to ask all of you some of your experiences around feeding back and what your approach and thinking is to, not just the data collection, but the use and the feedback of that data. Audience, timing. Maybe we'll start with you, Brianne.
Yeah, absolutely. Great question, because I think it's a point that's not always focused on. And so feeding back to who is something that we often talk about. And it's really, I'm like mid sort of data presentations this week, as a matter of fact. And so I'm just trying to reflect on sort of what's going on there. And actually, we're not even at the evaluation stage. We are at the planning stage and interpreting. And some of the health system language I've heard is validation. So we're getting the validation. And because a lot of the partners I work with are Ontario Health Teams, which is a collection of different health service providers, we usually go to the Ontario Health Teams to advise who should be at these meetings. And usually like they're doing amazing work, again, with the collaboratives, with the collectives, having patient and community member voices there. And that's just in the planning stage. So I think, it's that ongoing communication and just keeping people in the loop. Often it is in virtual meetings. I mean, especially as we're going into winter, no one is traveling. I'm sure the northern people can relate to that. But sometimes it's just an email too. But like most of the time it's tell us, like, here's what we think, tell us. And then there's the so what, but that's where we're going. I have more of those conversations to have.
Yeah, Reham, what about you for feedback? I mean, you certainly had a couple dashboards, so you were showing up. Or
yeah, it's just an example. So we do have dashboards for like everything we do, but I think an important aspect to think about when you're talking about data sharing is to start with engagement in the evaluation planning and design and the tool selection and design. And then when the providers or the patients are engaged early on, they will ask about the results. If they're part of the process, they will be very interested in knowing what happened with these tools. You said this evaluation plan like last year. Did you collect data? What did you do with this data? And then you will start setting this accountability structure within the teams. And like they become accountable to each other and then to the public. So whether it's like public reporting and stuff like that. And also you need to think about tailoring the outcomes of your evaluation based on the audience. So the data that you're sharing with the frontline providers might be a little bit different than the data you're sharing with leadership, for example. because the decisions that are expected based on this data is different based on who the audience is. So I think these are all kinds of important considerations while you're thinking about sharing the data.
So I think a good point around possibly different metrics or different approaches to data for different audiences too. Catherine, what's your experience like?
Yeah, I'm going to focus on the patient. So we're calling it the Wellness and Experience Survey, just mainly because for a few things. One, we know that people are really keen to hear about outcomes, not just like hospitalizations, health use, but actually like the wellness of our population. So we're laser focused on working with all of our primary care networks to help them because they have to report to QI anyway. So again, they're going to be keen to hear back from the outcomes of the survey, but we're also hoping to roll it up and aggregate this. And we're hoping eventually to get to a fancy dashboard like Reham, but more from a OHT. So what we're really hoping is to be able to share on a rolling basis, like what is the wellness and health of our OHT and the experiences people are reporting, and have that, because we feel like that's meaningful for both the people, but also primary care.
Thank you. Okay, we're coming close to the time, and I see there's more questions now being popped into the chat. So I'm going to put different questions to different people, so we can have a little bit of a. There's one of these, and I think Reham, I'm gonna bring this first one to you around the talking about how your OHT balances evaluation direction setting. So what you want to be evaluating with tangible work. This is from Shelley Horrocks, between your measurement and evaluation working groups and the backbone team. So I think like that's a little bit of what you think is important for evaluating, what you think is important for performance reporting, and then where those tasks fall.
Yeah. This is actually a great question. I think there needs to be some work, like some change management happening at the beginning by identifying like the difference between evaluation, reporting, performance measurement, and why each one is important on its own, but also how to connect them in a way. So for instance, we've been building these evaluation plans for each of our interventions over the last few years. This year, as we're part of the I-12 and we're looking more at like system level impact, we start like thinking, okay, how can we put these together to form this overarching framework? So it's the opposite of what you're saying, Catherine. Like you created the big picture first, and then you're trying to do the smaller ones. We started small, but then now we're going the opposite way. Let's put them together to see a system level impact. So what are these indicators that can be matched across all our programs from an integrated system perspective? So it's all about just find a place to start. Be sure that you are transferring your message to every single person who would be touched by this evaluation, whether it's the data collection or the results, and then build from there.
Yeah, thank you very much. And Brianne, you answered Brian's question that I was going to put to you. So thank you for popping that one into the chat. So I leave off one minute, one question to Catherine. There was a question in Leslie Eckel asking about interoperability or standardization and consideration. Are the indicators that you're choosing, how important is it that they be validated and reliable?
Yeah, I mean,
you're a scientist, so this is not an easy question for you to say.
Yeah, no, that is what we really strive for. And I'm just thinking about, that's why we've landed on, when we say our patient wellness and experience survey, Walter, we were guided by your work with the HSPN Prem and Prom survey, and thinking about the EQ5D, we know it's highly used across multiple systems populations. So we're landing on that as one of our core outcomes to think about, like patient outcomes. And then we're thinking about also using the CHC standard set of questions for health equity and describing our population. So like as much as we can, like laser focused using on things that have been put out in the literature, but that also people can use across OHTs, because we don't want to just develop another set of questions or outcomes. So that's laser focused, but also I have 1 minute left, is to be thinking about how we can use the same things across multiple populations and evaluation so we can bring the data together.
Yeah, thank you very much for that. And I'll say it's our approach as well. Lali, you could bring up the slide towards our end here, to thinking about not trying to reinvent things all the time, right? And trying to use as much as possible. So we're going to slide down here to the end of the slides. And I think there's just so you know, up next, we continue to come every Tuesday. But the fourth Tuesday of the month is very, very close to Christmas. So we'll actually be back in January. And we're looking at brakes and accelerators in learning health systems. So the last part of this learning health system are the top end, the brakes, the accelerators, the things that can support or impede all of the mechanisms from working. And finally, on the last slide, if you open up your cameras and take like 60 seconds after this event, give us a little bit of feedback. And maybe if you have ideas for future events, we're planning it for the next 2, but then we're really looking to start up another new series. This has been really, I think, insightful for us to have gone through all of the gears around the learning health system and learned how they each interoperate and activate, and hopefully building a strong platform for all of the Ontario health teams in this regard. Thanks everybody so much for joining us today. Such great thanks to Drs Catherine Donnelly, Reham, Abdelhalim, and Brianne Wood for being with us and sharing the strength and the wealth that exists in OHTs. Thank you very much.